Good afternoon, dear professors and colleagues. We are going to start the most interesting session. Actually, we are talking about very important topic, especially in Egypt. We are talking on special issues in young breast cancer patients, which is very common in Egypt. So we'll start the session with the presentation held by Professor Dr. Amira. Is Professor Dr. Amira, I'm sorry, Professor of Medical Oncology, NCI.
Bismillah ar-Rahman ar-Rahim. Good evening. Dear chair ladies and dear audience, it's my pleasure to participate in Baheya. I'm Dr. Amira Dia, Professor of Medical Oncology, NCI, and a consultant at Baheya. It's my pleasure to participate in this meeting and in this hot topics, the session of the oncofertility. I'm gonna talk about risk of cancer treatment related ovarian failure. Here's my agenda. Gonadotoxic therapy, whether surgery, radiotherapy, or chemotherapy, had a risk of ovarian failure in young women. It's most commonly described in survival of breast cancer, childhood cancer, and Hodgkin lymphoma. It's associated with reduced health-related quality of life and sexual dysfunction. Ovarian failure is a significant late effect of cancer, especially in young women. It impacts fertility, hormonal balance, and quality of life. Ovarian failure is diagnosed. Has a different synonym. It may be a premature menopause, a premature ovarian failure, chemotherapy-induced amenorrhea, and primary ovarian insufficiency. Primary ovarian insufficiency is the preferred term, as ovarian follicular activity may intermittently recover, and the term premature implies a biologically arbitrary age cutoff 40 years for cessation of menses. The term primary ovarian insufficiency distinguishes an impairment that's intrinsic to the ovary, as opposed to the other non-ovarian or endocrine dysfunction, such as the hypothalamic pituitary disorder and adrenal disease. It is defined by menstrual irregularity for at least 3 consecutive months and follicle-stimulating hormone level above 40 international units per liter on 2 separate measurements spaced at least 1 month apart. Effect of primary ovarian insufficiency has short-term effect and long-term effect. Short-term effect, menstrual abnormalities, hot flashes, night sweat, impaired fertility. Long-term effect, it increases the cardiovascular risk, the bone mineral density, cognitive deficit, and sexual dysfunction. Incidence of ovarian failure by age group increase with age due to the declining ovarian group. And the cancer most type associated with ovarian failure, the breast, Hodgkin lymphoma, colorectal leukemia, and others. To talk about the ovarian failure, we have to mention the ovarian reserve. The ovarian reserve, there is a natural decline of ovarian reserve from birth till menopause. The primordial follicle in the ovaries are non-renewable. The follicles are characterized by, and the oocytes are characterized by high metabolic and DNA repair demand and susceptibility of change, the increase with age and cumulative dose of chemotherapy. The risk factor for ovarian damage include patient age. Older age at treatment is associated with higher risk. Chemotherapy agent and dosage, alkylating agent, the most common, and high dose regimen are highly gonadotoxic. Radiation dose and feed, pelvic or total body irradiation, baseline fertility status, lower anti-Mullerian hormone level or intrafollicular count before treatment. Published in July 2025, the FIGO best practice advice consider the cancer and fertility management. They mention the fertility risk in most of the cancer patients, and they found in breast, the alkylating agent, cyclophosphamide, and ovarian suppression carries a high risk of primary ovarian insufficiency. In cervical cancer, the pelvic irradiation and radical hysterectomy may cause infertility. Hematologic malignancy with the high-dose chemotherapy, the regimen of the BIACOP and the ABVD. Pediatric leukemia, where there is total body irradiation and alkylating agent. Total body irradiation risk about near 100% of ovarian failure. Thyroid cancer, either by the radioactive iodine or thyroidectomy impair the ovarian function. Colorectal cancer with pelvic radiation and the oxaliplatin-based regimen cause gonadal damage. Brain tumor affecting the hypothalamic pituitary dysfunction. Endometrial cancer through hysterectomy, progestin therapy, and sarcoma, the high dose of the alkylating regimen. Mechanism of damage. Gonadotoxic therapy, the radiation cause vascular injury and fibrosis. Surgery cause direct removal. Chemotherapy, and will be the main points of my discussion here. The chemotherapy, we have different types of chemotherapy agent, and here is a table. I don't know if you can see this. It's not clear. The busulfan is high risk for ovarian failure and infertility in all age group. Carboplatin and chlorambucil carries intermediate risk. The cyclophosphamide, according to the dose, carries the risk of ovarian failure. It's mentioned that according to age, when the age is less than 20 years and total cumulative dose is greater than 7 grams, it's high risk. When the age range between 30 and 39 years with total cumulative dose 5 grams per meter square, it carries an intermediate risk. And in older age of 40 years with total cumulative dose greater than 5, it's also high risk. For age between 20 and 39 years, at a part of the AC or the ACT taxol regimen for breast cancer, cyclophosphamide dose carries a low risk. Age younger than 30 years as a part of the FAC regimen or the CMF, it carries a low risk. And the cyclophosphamide dose in age younger than 35 years as a part of the CHOP protocol of the non-Hodgkin lymphoma carries low risk. Other chemotherapy carries between low and intermediate risk. Modern anti-cancer treatment for the hematopoietic stem cell transplantation, the risk is high, about more than 80%. External beam radiation to the field of the ovaries carries a high risk of 80%. CMF FAC in human age 40 and older, it carries a high risk of 80%. The CMF and the FAC regimen in women aged 30 to 39 years in the breast cancer therapy adjuvant, it carries intermediate risk. While the FAC and FAC regimen in women less than 30 years, it had a lower risk. Chemotherapy-induced ovarian damage is by 3 main mechanisms, either direct toxicity to the oocyte and the granulosa cells, direct cytotoxicity to the oocyte and granulosa cell, indirect damage to the follicular activation, which is the burnout phenomena, and stromal vascular injury. Direct cytotoxic drugs are known to induce large amount of DNA damage, either in the form of monoalkylation, intercalation, interstrand crosslink, and interstrand crosslink DNA damage. The DNA damage invite the TAP63 tumor suppressor gene. It's an homologue of the P53 suppressor gene, but present in the oocyte. TAP63 activate the apoptosis, and when the double strand cannot be, the repair mechanism of the DNA damage cannot be repaired, the TP53 is activated and it mediates apoptosis causing granulosa cell death and accelerate follicular loss. If there is double strand break and the repair system succeed, the follicle will survive, and if it doesn't succeed, also the apoptosis will carry and the ovarian reserve will decrease. Direct cytotoxic damage by the alkylating antimetabolite and the drug-specific cellular damage. Indirect mechanism, where the burnout mechanism, the chemotherapy suppress the AMH level and hence remove the inhibition of follicle activation. Follicles will be activated, and the term burnout means that the follicles are activated and ovulation will be done. However, this will not be used, and hence the number of ovarian reserve will decrease, and this cause accelerated depletion of the ovarian reserve. Stromal and vascular injury. Chemotherapy can cause microvascular ischemia and fibrosis. Stromal remodeling disrupt the follicular microenvironment, and impaired perfusion impairs long-term follicular survival. Endocrine therapy, long-term adjuvant endocrine doesn't directly kill oocyte, but deferring childbearing for years during treatment inevitably exposes egg to age-related decline in quality. Because of breast cancer treatment typically combines drug from multiple classes, and because each patient's baseline ovarian reserve and genetic susceptibility vary, it remains impossible to predict individual infertility risk by the regimen alone. Reliable marker of ovarian reserve include the AMH. It's a best predictor of ovarian reserve and recovery. The antral follicular count by the ultrasound correlate with the follicle pool size, and the FSH level, which is less reliable due to intercycle variability. Here, there is online and consensus risk stratification tools published in the group of the Cancer and Childhood Cancer Survival Survey. They found many tools, the online calculator and risk stratification publication, depending on the age and the treatment-specific risk of failure to begin menstruating after cancer treatment. These risk calculator can be used online and by computer to predict the risk of infertility and ovarian failure and hence infertility in the children. How to overcome the ovarian failure by fertility preservation strategy. I'm not going to talk about it because it will be in the coming lecture, but just an enumeration by embryo and oocyte freezing, ovarian tissue cryopreservation. Embryo and oocyte freezing is most effective and widely used. Letrozole or tamoxifen added to stimulation protocol to reduce estrogen exposure, and these can be safely used in breast cancer patients. Ovarian tissue cryopreservation is suitable for urgent cases, and over 130 live births is reported worldwide. Risk of cancer cells receding must be evaluated, especially in BRCA-positive patients. The GnRH analog may reduce the chemotherapy-induced amenorrhea risk, but evidence is mixed. It's not a substitute for cryopreservation. In vitro maturation is useful when stimulation is not feasible and requires expertise and has lower success rate. Hence, the cancer patient faces a barrier to the oncofertility care due to lack of standard practice. The oncologist knowledge, many oncologists lack the knowledge of full spectrum of fertility evaluation, preservation option, and referral resource. Sometimes we have to start treatment rapidly, and this actual urgency to start cancer treatment often leads to inadequate or missed fertility counseling. Low utilization, despite a desire for future fertility, utilization of preservation remains low due to concerns about cost, treatment delay, and psychosocial burden. The oncofertility in the coming years is a challenge due to increased survivorship. Advancement in cancer treatment mean more young women are surviving their disease. Measures infertility is one of the most significant long-term sequelae, severely affecting the quality of life and psychosocial well-being of young survivors. The potential loss of fertility can influence patient adherence to treatment or lead to selection of less effective therapy perceived to have lower infertility risk. The ASCO NCCN guidelines, healthcare provider should discuss the infertility risk and fertility preservation option with all reproductive age patients before they undergo oncologic treatment. Thank you.
Thank you, Dr. Amira Dia, for your elegant presentation, and the questions will be at the end of the session.
Thank you.
Thank you very much, Professor Dr. Amira, for this very interesting topic. I have a question for you. Actually, the deal with young breast cancer is very challenging for us. You have this topic is unique and challenging. If you have young patient with breast cancer, mostly she will present with advanced stage, and most of them, they need to plan for their family. So we don't have strict guidelines for such patients. We need to have guidelines, not case by case. We need to hear from you if you have some 1, 2, 3 guidelines for such patients according to the financial ability and psychological ability, everything, yani, and the resources available.
Yeah, guidelines.
So we have now some.
Yes, I will summarize the points that they are in literature. Upon my reviewing, they found that the most effective and the rapid method is the ovarian tissue preservation. This because the lady, she can do it and start chemotherapy after 1 week. As for regard the oocyte preservation, it needs time. She needs to take drug and wait for ovulation and then collect the ovum to be used there. I don't know whether how long does it take. Maybe the obstetrician can tell us how long does it take for ovarian stimulation and to retrieve the ovary in order to be stored before starting chemotherapy. But nowadays we use, and there is, according to the POEM study, we can use the Zoladex with chemotherapy in order to prevent the phenomenon of the burnout or to decrease the consumption of the ovarian reserve during the cycles of chemotherapy. Also, when using the hormonal treatment, Zoladex added to the hormonal treatment can help the lady to regain fertility and ovarian function after end of her treatment.
Thank you, Dr. Amira. Do we have any other questions? Do we have any question from the floor? Thank you, Amira.
Thank you.
I get this issue of fertility preservation will be more elaborated by Dr. Amra Abul-Yazid, who is a senior consultant of OBGYN. And at the same time, if I may add, he is Secretary General of a very important conference in Egypt, who is now at the top of the calendar, which is the National Conference for Women Health. دكتور عمرو.
طبعا برحب بحضراتكم جميعا واتشرفت بالدعوه الكريمه النهارده من مؤسسه بهيه، وبرحب بالتشير بيرسونز الكرام. موضوعنا النهارده على الأونكو فيرتيليتي كونسلنج والأوفيريان بريزرفيشن استراتيجيز ان بريست كانسر. I'm دكتور عمرو ابو اليزيد، دايركتور اوف فانكشنال جينيكولوجي انستيتيوت، وهنقدم النهارده زي نبذه كده عن الفانكشنال جينيكولوجي بروتوكول within the conventional strategies in ovarian cancer ovarian preservation. حد عارف اي حاجه عن الفانكشنال جينيكولوجي؟ الفانكشنال جينيكولوجي ده new emerging women health science based on 4 main pillars. في 4 محاور رئيسيه. اول واحد هو الفيرتيليتي كير، تاني واحد هو السكشوال هيلث، تالت واحد هو اللايف ستايل ميديسن، ورابع واحد هو الومن منتال هيلث. الفانكشنال جينيكولوجي كونسبتس هو عباره عن integration between these 4 main pillars in management of every reproductive and gynecological health موجود في الفانكشنال وومن ويل بينج. الوومن فانكشنال ويل بينج ده التارجت بتاعنا، تمام؟ احنا عاملين highly specialized women health care programs في الفانكشنال جينيكولوجي انستيتيوت in every age group في اللايف سايكل بتاعت الفيميل. عندنا puberty program، child bearing program، menopause program، وعندنا highly specialized programs زي الكانسر patient rehabilitation program والفيميل جينيتال ميوتيليشن ريهابيليتيشن بروجرام والاثليت وومن هيلث. احنا النهارده هناخد برضو هنجو ثرو البروجرام بتاع الكانسر بيشنت ريهابيليتيشن في التوبيك بتاع النهارده. هنبدا بانكولوجي اونكو فيرتيليتي كونسلنج اوفر فيو. لازم نعرف ان ليه الموضوع ده مهم، ليه الاونكو فيرتيليتي مهم. انا ما اعرفش في حاجه في مشكله في البتاع ده. طبعا مع الادفانسز بتاعه التريتمنت اوبشنز في الكانسر بيشنت تريتمنت وخصوصا في البريست كانسر ارتفع جدا الايه؟ السرفايفل ريتس. السرفايفل ريتس حد يعرف احنا يعني كم عدد السنين اللي ممكن الست تعيشها بعد الكانسر up to with the side effects of cancer treatment modalities. يعني ممكن الكانسر treatment modalities تقعد تأثر على الكواليتي اوف لايف بتاعة الفيميل up to how many years? How many years?
I answered this. Long time.
ما هو quality of life along survivorship بتاعتها along their life
Have long-term adverse effects.
up to ايه؟ up to 20 years. تخيل.
لا
انا بتكلم ان الافكشن اوف كواليتي اوف لايف والسايد افكتس بتاعت الكانسر تريتمنت موداليتيز ممكن تقعد مع الست حتى 20 سنه. حتى 20 سنه كسايد افكت. عشان كده الكواليتي اوف لايف هي المهمه. تمام. الكواليتي اوف لايف هي المهمه. وطبعا لما نيجي نتكلم عن الكواليتي اوف لايف الفيرتيليتي از رايزنج اب as a significant affection للكواليتي اوف لايف. زيها زي السكشوال هيلث، زيها زي الماريتال لايف از هول. طبعا عشان الفيرتيليتي از ا كواليتي اوف لايف ايشو لازم ايرلي كونسلنج بنفيتس، ليها ايرلي كونسلنج بنفيتس، وعشان كده اتحطت في الجايد لاينز بتاعتنا as mandatory from day one of diagnosis للكانسر وسبيشالي البريست كانسر عشان نقدم الايه الفيرتيليتي كير اوبشنز. هنناقش الاول الفيرتيليتي ريسكس والمانجمنت اوبشنز المتاحه. طبعا الدكتوره اتكلمت يعني سريعا عن الاوبشنز المتاحه، بس لازم نبقى عارفين ايه هي الريسك فاكتورز اللي بتاثر على الفيرتيليتي كير اللي احنا بنقابلها مع الكانسر بيشنتس. اولهم هو طبعا الايدج، زي ما الدكاتره قالوا الايدج والاوفيريان ريزيرف مدته. كل ما الايدج كان اقل في يانجر بيشنت كل ما الاوبشنز كانت احسن، وكل ما الاوت كامز والبروجنوزس كان افضل. الاوفيريان ريزيرف، الثيرابي تايبس زي الالكاليتنج كيموثيرابي او الهرمونال ثيرابي ده بيأثر على الاوفيريان فانكشن وجونادوتوكسيك اوت كامز بتاعت الاوفريز. تحت سن ال 35 سنه has better spontaneous ovarian recovery but still vulnerable to ايه جونادوتوكسيسيتي. الايرلي اسسمنت مهم عشان نقدم personalized care. لو في ايرلي اسسمنت هيبقى قدامنا اوبشنز. لو احنا كالعاده بيجي لنا ليت ريفيرال او ما بيجيلناش ريفيرال اساسا، ده بيبقى ايه الاوبشنز بتقل. في established fertility care methods او fertility preservation methods موجوده في الجايد لاينز زي ما الدكتوره ذكرت، وموجوده في الاي سي او جي الامريكان كولج اوف اوبستاتريكس اند جينيكولوجي، موجوده في الاشري جايد لاينز. والستاندرد اوف كير في الفيرتيليتي بريزرفيشن مع الكانسر بيشنتس هو الاوسايت كرايو بريزرفيشن والامبيريو كرايو بريزرفيشن. طبعا البيست والهاي ريت اوف سكسس هو الامبيريو كرايو بريزرفيشن، بس الاوسايت از رايزنج فور ماني ييرز. وده الستاندرد كير بتاع الفيرتيليتي بريزرفيشن في التشايلد بيرنج بيريود. وبنقدم برضو الاوفيريان تيشو كرايو بريزرفيشن، بناخد سلايس من الكورتكس بتاعت الاوفري باللاباروسكوب از اوبتيمم براكتس، وبنعمل لها كرايو بريزرفيشن. ده لو في حاله الستاندرد ميثودز اوف كرايو بريزرفيشن او فيرتيليتي بريزرفيشن مش متاحه، اللي هي الاوسايت والامبيريو كرايو بريزرفيشن، وبنعمل لها كرايو بريزرفيشن الاوفيريان تيشو نفسه زي في البيوبريتي وفي البري بيوبريتي. يعني في البري بيوبريتي كانسرز والبيوبريتي كانسرز او اي ايشو او كونترا انديكيشن او نوت فيزيبل ستاندرد ميثود بنعمل الاوفيريان ايه كرايو بريزرفيشن. الادجنكتيف تريتمنتس with GnRH agonist during chemotherapy بيقلل الاوفيريان دامج. ولازم نبقى عارفين ان GnRH agonist not a method for fertility preservation but هو adjunctive method، هو عامل مساعد، هو بيساعد الايه الكيرنج اوف fertility during chemotherapy والحاجات دي. في اوبشنز بنقدمها في الفانكشنال جينيكولوجي عن الفيرتيليتي كير بوست تريتمنت. يعني احنا دلوقتي جالنا كلاينت او كانسر بيشنت ومش متاح ان احنا نعمل لها fertility preservation options قبل التريتمنت. هو كده انتهى الموضوع؟ لا، ما انتهاش الموضوع. تاخد GnRH agonist عشان تقلل ال to protect الاوفريز، وبنقدم لها surface of NAPRO technology and create a model fertility care system post cancer treatment. NAPRO technology is a new emerging woman health science, stands for natural procreative technology. Natural procreative technology. ودي is the best option post treatment especially in younger females. وطبعا it's natural وcooperative وبتماشيه مع بالذات الهرمونال sensitive cancers. بس دي محتاجه عشان نشرحها محتاجه يعني محاضره لوحدها. الاوسايت والامبيريو كرايو بريزرفيشن زي ما قلنا ده الستاندرد كير في الفيرتيليتي بريزرفيشن. والاشري والامريكان كولج اوف اوبستاتريكس اند جينيكولوجي في 2025 طلعت الجايد لاينز بتاعها في هذا الموضوع using الراندوم ستارت بروتوكول. الراندوم ستارت بروتوكول ده وفر saving time في الفيرتيليتي بريزرفيشن على الكونفنشنال بروتوكولز بتاعه الاندكشن بتاعه الاوفيوليشن. وبالتالي الراندوم ستارت بروتوكول ده ممكن نبداه في اي وقت في السايكل، في الفوليكولار فيز، في اليوتيل فيز، ايفن في الليت اليوتيل فيز. فبنبدا راندوملي ايا كان الفيرتيليتي سايكل او المينسترال سايكل بتاعت الفيميل دي اكتشافها كان امتى، بنبدا الراندوم ستارت بروتوكول مع الليتروزول يوز. فعشان كده بنبدا راندوم ستارت استراتيجي مع بلس الليتروزول، عشان الليتروزول بيقلل الاستروجين ليفلز وبالتالي up to 70% بيقلل الاستروجين ليفلز وخصوصا في الاستروجين بوزيتيف ريسبتورز. والاستاديز اللي اتعملت على الراندوم ستارت بروتوكول مع الليتروزول استراتيجيز has favorable outcomes سواء بالنسبه للفيرتيليتي بريزرفيشن او للكانسر تريتمنت موداليتيز. الراندوم ستارت اند بلس ريتروزول استراتيجي بلس هم كومبايند، يعني بنعمل راندوم ستارت للاندكشن اوف اوفيوليشن بلس الريتروزول عشان نقلل الاستروجين ليفلز وهاز كلينيكال سيفتي اند افيكاسي، وبيعمل بيوفر الايه الارجنت فيرتيليتي بريزرفيشن جول. احنا عندنا هدف اللي احنا نعمل urgent fertility preservation. فالراندوم ستارت ده بيوفر، احنا عارفين ان الكونفنشنال اوفيريان اندكشن في اوفيوليشن اندكشن في الحالات بتاعه الاي في اف او في الاوردينري كيسز وزاوت كانسر ممكن تقعد من شهر لشهرين. لكن الراندوم ستارت بروتوكول، وده اجابه السؤال اللي حضراتكم سالتوه في المحاضره اللي فاتت، احنا ممكن الراندوم ستارت بروتوكول من 10 ايام ل 12 يوم نكون عاملين اوفيوليشن اندكشن وعاملين ريتريفل، يعني 12 يوم نكون مخلصين البروتوكول بلس ان احنا بنسيب تقريبا اسبوع بعديه عشان داون ريجوليشن بعد التريتمنت، يعني اب تو 3 ويكس ات ليست عشان نعمل ستاندرد كير في الفيرتيليتي بريزرفيشن. الاوفريان تيشو كرايو بريزرفيشن ده emerging throughout the previous years as an alternative options للأوسايت والإمبيريو كرايو بريزرفيشن. طبعا في ده بيتعمل زي ما قلنا maybe باللاباروسكوبي عشان نقلل الوونس اللي موجوده عشان نقدر نبدا ستارتنج التريتمنتس او كيموثيرابي as soon as possible، ما يبقاش في سيرجيكال يعني نقلل التايم بتوين ذا سيرجري وما بين الستارت بتاع الكيموثيرابي. وده بيتحط كرايو بريزرفيشن، وده اوبشن زي ما قلنا في البري بيوبيريتال والبيوبيريتال واي كونترا انديكيشن موجوده في العيان اثناء ساعتها، يعني اثناء اكتشاف الكانسر، وكونترا انديكيشن للاوسايت والامبيريو كرايو بريزرفيشن. طيب هو في ثيوريتيكال ايشو بالنسبه للاوفيريان تيشو كرايو بريزرفيشن. الثيوريتيكال ايشو ده ان هو بيعمل مع الري امبلانتيشن لما بنزرعه تاني جوه العيانه اللي هو بنري انتروديوس مالجنانت سيلز، بس ده اكتر في حاجتين، في الميتاستاسيز، يعني لو بنتكلم على كيس بريست كانسر وفيها ميتاستاسيز ايا كان الميتاستاسيز ده فين، معناه اللي هو دخل بقى الليمفاتيك والبلاد ستريم والكلام ده، فاحنا في ثيوريتيكال ري امبلانتيشن ايشو. الحاجه الثانيه الليوكيميا او الهيماتولوجيكال كانسرز، يعني الستات اللي عندهم هيماتولوجيكال كانسرز دول شويه في ليميتيشن للاوفيريان تيشو كرايو بريزرفيشن. عشان كده هو مش فيرست لاين او مش ستاندرد كير، بس هو الترناتيف اوبشن للستاندرد كير بتاع الاوفيريان بريزرفيشن. وطبعا احنا لما بنيجي نعمل ري امبلانتيشن للاوفيريان تيشو احنا فيه يعني برضو لمعلومات حضراتكم هو في حاجتين، يا اما نعمل لها حاجه اسمها اورثوتوبيك ري امبلانتيشن، بنزرع الكورتيكال تيشو ده في نفس الاوفري اللي احنا خدنا منه السلايس دي من الكورتكس، او بنزرعها في الاوفيريان فوسا في البريتون في البلفس، وبالتالي ده ممكن يزود الاوبشنز بتاعت الايه الناتشرال كونسبشن، يعني جنب الفالوبيان تيوب ويحصل اوفيوليشن تاني، وممكن يزود الاوبشن بتاع التشانسز بتاعت الناتشرال كونسبشن. الهيتيروتوبيك بقى ري امبلانتيشن اللي احنا بنزرع السلايس بتاعت الاوفيريان تيشو دي في اي مكان تاني خارج البلفس زي الفور ارم او الثاي او في الابدومينال وول او في الابدومينال بريتون، وكل دي ترايلز اتعملت في اماكن كتير على مستوى العالم. بس هي with rising evidence، يعني الاوفيريان تيشو كرايو بريزرفيشن now with rising evidence. جي ان ار اتش اجونست ثيرابي زي ما قلنا بيستخدم alongside الكيموثيرابي to preserve الفيرتيليتي لو الايه الكرايو بريزرفيشن اوبشنز مش متاحه. هو بيعمل سبريشن للاوفيوليشن، وبالتالي احنا بيخبي الاوفريز، بيدخلها في كويسنت ستيت، بيدخلها في مينوبوز ستيت، في سليب ستيت، وبالتالي لما تاخد الكيموثيرابي احنا عارفين ان الاوفريز او الجونادز دي اتس زي ما نقول ايه خلايا ناشطه، فهي بتخبيها من الكيموثيرابي عشان ما تتاثرش جامد بالافكت بتاع الكيموثيرابي والتريتمنت موداليتيز بتاعه الكانسر تريتمنتس. اتس جود اوبشن فور adjunctive treat كعامل مساعد للفيرتيليتي بريزرفيشن. ولازم نناقش الموضوع ده مع كل عيان ونحدد لهم البينيفيتس ايه والليميتيشن ايه. تمام، يعني ده مش جورانتيد الاوفيريان فانكشن هترجع تاني لطبيعتها. هو فور شور الاوفيريان فانكشن بتتاثر والهرمونال ليفلز بتتاثر بعد الكانسر تريتمنت موداليتيز زي ما قلنا up to many years بعد التريتمنت. عشان كده ده في ريهابيليتيشن بروجرام للموضوع ده بالذات، الريهابيليتيشن للفيرتيليتي كير وللسكشوال هيلث اللي هي بترفلكت الهرمونال امبالانس اللي بيتم مع الكانسر تريتمنت موداليتيز. ايه البروتوكولز والامبلمنتيشن؟ لازم نقول عشان السيفتي بتاعت الانكولوجي اوتكمز والبريجنانسي ريتس احنا بنستخدم كفيرتيليتي كنترول الاي يو سي ديز اور كريتو موديل فيرتيليتي كير سيستم، وده ناتشرال سيستم بيقدم الترناتيف اوبشنز للكونتراسبشن. احنا بنقول عليه اللي هو فيرتيليتي كير نوت فيرتيليتي كنترول، وبيمونيتور الهرمونز بتاعه الفيرتيليتي سايكل بتاعه الفيميل سواء اثناء العلاج او بعد العلاج and throughout life in addition to letrozole. وده بيقلل الايه السايد افكتس او الاوت كم بتاع، يعني ما بيأثرش على الاوت كم بتاعت التريتمنت. والبريجنانسي افتر كانسر طبعا ما بيتأثرش الريتس بتاعته ولا الاوت كمز بتاعته مع الحاجات دي سبيشالي في اليونج ايج. بس كل ده لازم يتم من مالتي ديسيبلينري تيم. التايمنج كل ما احنا في طبعا في الفانكشنال جينيكولوجي انستيتيوت يعني لازم يبقى فيه structured stepwise approach. الستراكشرد ستيب وايز ابروتش ده اتس بيرسوناليزد زي ما قلنا في اول كيس. البيرسوناليزيشن ده هو اللي بيقدم، والايرلي كونسلنج او الايرلي انترفنشن هو اللي بيمنحنا الخطط اللي احنا ممكن نقدمها لكل عيان. كل ما نعمل ايرلي انترفنشنز كل ما يبقى قدامنا اوبشنز كتيره، وبنقدم رابيد انترفنشنز ويزن دايز. يعني احنا لازم الكونسلنج بتاع الفيرتيليتي كير ده لازم يكون في خلال 48 ساعه ل 72 ساعه من الانيشال دايجنوزس، وده التارجت بتاعه هو الانكولوجيست، لان الانكولوجيست هو من اوائل الناس اللي بيقابلوا الايه البيشنت. ولو مش الانكولوجيست هيريفير. نعم الراديولوجيست طبعا، بس هو يعني الراديولوجي في الدايجنوزس طبعا احنا بنتارجت الاثنين، ان الراديولوجيست والانكولوجيست هم اللي يعملوا ريكومنديشن للبروسيس بتاعت الفيرتيليتي كير within 48 hours من الانيشال دايجنوزس، عشان نحاول ان احنا نيفالويت الكانسر ريسكس وناخد ديتيلد هيستوري فانكشنال جينيكولوجي اسسمنت والسكشوال فانكشن باي ذا هيومن سكشواليتي اندكس. الهيومن سكشواليتي اندكس ده اتس انوفيتيف تول خاصه بالفانكشنال جينيكولوجي انستيتيوت، هي الوحيده وورلد وايد اللي بتيفالويت السكشوال ريليشن شيب ما بين التو كابلز. الاميديت كونسلنج والاديوكيشن للفيرتيليتي اوبشنز والريسكس بتاعت الفيرتيليتي. لو العيانه مع الانيشال دايجنوزس هي طبعا اكوردنج للايدج واكوردنج للفيرتيليتي ديزاير، يعني هي واحده لسه صغيره متجوزه جديد، عايزه لسه ما عندهاش اولاد، عايزه فيرتيليتي بريزرفيشن، فلازم بنقدم لها الاوبشنز بتاعه الكرايو بريزرفيشن سواء الاوسايت او الامبيريو. والامبيريو طبعا ما دام هي متجوزه هنعمل امبيريو كرايو بريزرفيشن. طب لو هي فيرجن يبقى الاتجاه على الاوسايت كرايو بريزرفيشن. طب لو هي كومبليتنج هير فاميلي ومش محتاجه اوريدي عندها 4 اولاد ومش عايزه تحمل تاني تحت اي ظرف، خلاص يبقى احنا بنتجه خلاص هنبعد عن الكرايو بريزرفيشن، بس لازم ندوكيومنت ولازم نقول لها عليها ونترك لهم هم الايه الاختيار. بعد كده الاوبشن اللي احنا هندي جي ان ار اتش اجونست مع الليتروزول والتريتمنت، وهنقدم لها اللي فيه فيرتيليتي كير استراتيجي بوست تريتمنت عن طريق النابرو تكنولوجي. النابرو تكنولوجي it's a good alternative option, it's natural choices for contraception for avoidance of pregnancy and pregnancy achievement. ودي alternative للكرايو بريزرفيشن. الناس اللي ما لحقتش اللي هي في بريزرفيشن اوبشن للفيرتيليتي قبل، لا عندنا النابرو تكنولوجي اوبشنز بعد. الكونسلنج بوينتس زي ما قلنا بندسكاس الانفيرتيليتي ريسكس بتاعت الكانسر تريتمنتس، الفيرتيليتي بريزرفيشن تايمينج. احنا خلاص فاضل لنا 1 سلايد ممكن. الفيرتيليتي بريزرفيشن تايمينج والليجال والايثيكال ايشوز، وبنقدم المالتي ديسيبلينري سرفايفرشيب بلان مع الانكولوجيست والانكوسيرجن، ومن خلال الايفالويشن بتاعت السكشوال ريليشن شيب والمنتال ريليشن والمنتال وومن منتال هيلث واللايف ستايل ميديسن ابروتشز في الكانسر. اقلب بقى، اقلب، ما بقلبش. على العموم يا جماعه احنا خلصنا، يعني هي دي كانت كيس برزنتيشن، بس احنا جو ثرو الموضوع كله في السايكل. ليه؟ الكيس برزنتيشن دي واحده صغيره عندها 32 عندها 32 سنه، هي جايه استروجين ريسبتور بوزيتيف وستيج 2 كانسر تريتمنت. دي بنعمل لها الفيرتيليتي اسسمنت، هي ديزايرنج الفيرتيليتي بريزرفيشن. طبعا بنعمل لها الراندوم ستارت بروتوكول مع الليتروزول استراتيجيز. طبعا هو في ديتيلد بروتوكول، يعني انا مش عارف لو في جاينيكولوجيست حابين يعرفوا الديتيلد بروتوكول بتاع الراندوم ستارت استراتيجي دي عباره عن ايه، بس ممكن نتكلم في التايمنج يعني في الاسئله. وكل ده عن طريق برضو الكوردينيشن ما بين الانكولوجيست والايه والفيرتيليتي كير بروفايدرز. وزي ما قلنا في 4 باريرز الاربعه باريرز دول اللي موجودين في مجتمعاتنا في العموم، هو اللاك اوف oncologist awareness، وده اول ايشو. تمام، الانكولوجيست هم اول ما يدايجنوز لازم تاني يوم يبدا العلاج ايا كان العيانه دي ملوش دعوه، فده لازم تريز الاويرنس. عشان كده احنا معاكم النهارده ماشي، عشان بنريز الاويرنس بوست للفيزيشن وللبيشنتس ماشي. تاني حاجه التايم ليميتس، يعني التايم ليميتس احنا وصلنا من اسبوعين ماكسيموم 3 اسابيع approaching الفيرتيليتي بريزرفيشن الستاندردز. وفي alternative strategies. طبعا الكوست، الموضوع ده بيكوست طبعا العيانه، فهو ادد كوست ومفيش انشورنس بيغطي الموضوع حتى الان. وبور اكسس للفيرتيليتي سيرفيسز، مش كل العيانين ممكن يوصلوا للايه للبيست فيرتيليتي سيرفيسز اللي موجوده. عشان كده بنقدم establish rapid referral pathways في الفانكشنال جينيكولوجي كلينكس، بنقدم سبورت سواء educational سبورت للكولابوريشن مع الفيزيشن او patient centered awareness. ولازم يبقى من خلال collaborative network. التيك هوم مسج الايرلي كونسلنج، ايرلي كونسلنج للفيرتيليتي اوبشنز، ده اهم حاجه وده مش موجود. انا عايز اقول لكم ان هو ما فيش، هم الانكولوجيست هم المستأثرين بالعيان، ما بيودوش لحد تاني. تمام. الستاندرد بريزرفيشن ميثودز هو الاوسايت والامبيريو كرايو بريزرفيشن. الاوفريان تيشو كرايو بريزرفيشن ده emerging options في كيسز معينه مش متاحه فيها الاوسايت والامبيريو كرايو بريزرفيشن. الالترناتيف بريزرفيشن ابروتشز مع جي ان ار اتش اجونست والبوست كانسر تريتمنت من خلال النابرو تكنولوجي وكريتو موديل فيرتيليتي كير سيستم ابروتشز، ودي مهمه ودي ايمرجنج ودي جاست اكسكلوسيف للفانكشنال جينيكولوجي انستيتيوت. المالتي ديسيبلينري كير هو البيست مانجمنت او بلان اوف كير للبريست كانسر بيشنت. شكرا لحسن استماعكم واسف للتطويل. شكرا.
You raised a lot of issues that need to be discussed and clarified in 5 minutes. Let me start. Are you working and proceeding for national guidelines concerning the fertility preservation among young cancer patients in general? Because this is a very important issue. Secondly, the patients are treated within a multidisciplinary team, MDT. But you are right, we are lacking the issue of fertility preservation. It's not actually discussed, and not so many centers will discuss this, and patient education. So let me go back to the guidelines. Are you working? We need it.
Okay. First of all, I am a member in the Supreme Committee of Obstetrics and Gynecology Guideline Development Group في الناشونال جايد لاينز في المجلس الصحي المصري. وبنحط جايد لاينز لسه بادئين يعني over the past 2 years. احنا خرجنا حوالي 8 جايد لاينز بس لسه ما تطرقناش في الناشونال جايد لاينز للسبيشال ايشوز دي. يعني احنا شغالين لسه في الناشونال جايد لاينز على الجنرال جايد لاينز بتاعت النساء والولاده، بس ان شاء الله هنحطها في السكوب بتاعنا. بس بره طبعا هم في الامريكان كولج وفي الاشري دي حاجات اسوشيشنز خاصه والازمو حتى مطلعين fertility preservation options. فاحنا ان شاء الله في القريب باذن الله هنهايلايت في الناشونال جايد لاينز بتاعت مصر البريزرفيشن اوبشنز. واكوردنج للسؤال الثاني بتاع حضرتك، في الام دي تي هي موجوده تقريبا في كل الاماكن اللي بتقدم بتاع، بس ما فيهاش fertility care specialist. يعني هي مدخلين فيها كل شويه بيستحدثوا يدخلوا فيها حاجه يستحدثوا. واحنا طبعا بنناشد من خلال الكونفرنس ده وبهي باعتبارها هي بتتعامل مع الفيميلز بس، فبالتالي البريزرفيشن اوبشنز الفيميل دي طبعا مهمه. فلازم يبقى في الام دي تي بتاعت البريست كانسر لازم يبقى فيها جاينكولوجيست، مش لازم نقول فانكشنال جاينكولوجيست بس، اضعف الايمان يبقى فيها دكتور نسا سبيشاليزد في الايه، في الفيرتيليتي بريزرفيشن والريهابيليتيشن. لان الريهابيليتيشن اوبشن بعد التريتمنت ده عايز اقول لكم يعني اهم من اللي هو يكون موجود. يعني طبعا الانيشال اسسمنت والاوبشنز تريتمنتس موجوده مهمه، والريهابيليتيشن ثرو اوت ذير لايف سواء في السكشوال هيلث سواء في الفيرتيليتي واذر ايشوز جاينكولوجيكال ايشوز دي مهم. احنا بنقول السايد افكتس ممكن تقعد اب تو ماني ييرز بعد التريتمنت وانتهاء التريتمنت والتوتال كيوريتيف، يعني هي خلاص كيوريتيف ريت بس معاها سايد افكتس ممكن تقعد فيها كتير في الايه، في الجاينكولوجيكال والريبرودكتيف ايشوز. فعشان كده اتس مانداتوري، يعني ان شاء الله تتحط باذن الله في المستقبل في مصر باذن الله. في اي اسئله تانية؟ انا مش عايز.
لا
اتفضلي
في
يا دكتور.
اسئله.
دكتوره ايمان عايزه تسال. اتفضل.
Okay. First, I would like to thank you for this amazing and very excited information.
شكرا.
It's very important for us, our very happy news that we have already strategies for fertility preservation in Egypt, but we don't know anything about it. So, like you are, أنت بتناشدنا ان احنا نكون معاكم في الام دي تي. احنا كمان بنناشد حضرتك ان احنا we should interfere even in the protocol you mentioned, because يعني the fertility planning for the patient it depends on so many things يعني not only the stage of disease.
Yes.
يعني we need molecular biology of the disease, we need some testing, genetic testing to know the patient when and how she will get pregnant يعني I mean. Now I asked you to mention about the success rate and the cost for the oocyte cryopreservation and the ovarian function, ovarian tissue preservation, the exact cost to inform the patient before referring for you. This is the first point. And how much is the success rate and what the difference between them? Because I know now it's contraindicated, the ovarian tissue in metastatic disease. So how much the success rate and the cost of each of them? And please send us or circulate your protocol for all the hospital to know it, or the oncologist.
For sure.
Mhm.
يعني طبعا السكسس ريتس هي اعلى سكسس ريتس في كرايو بريزرفيشن هو الامبيريو كرايو بريزرفيشن. الامبيريو كرايو بريزرفيشن ده البريجننسي ريتس بتاعته بتبقى عاليه اب تو يعني 40% تمام ل 50%. الامبيريو كرايو بريزرفيشن لو سايتس، لو احنا اتكلمنا على الاو سايت كرايو بريزرفيشن من 10 سنين كنا هنلاقيه اللي هو اساسا مش موجود. فطبعا الاو سايت كرايو بريزرفيشن سبيشالي في الفيرجنز وفي في الحاجات اللي هي مش متجوزين او اللي عندهم اي ايشو، طبعا بيبقى السكسس ريت بتاعه اقل شويه من الامبيريو، واقلهم خالص هو الاوفيريان تيشو كرايو بريزرفيشن، وهو رايزنج ايفيدنس، هو عليه ستاديز وورلد وايد وليه تكنيكس. يعني طبعا اللاباروتومي بيبعد شويه الكيموثيرابي انترفنشن عشان الجرح اللي موجود، لكن اللاباروسكوبي اتس ا جود اوبشن اند الترناتيف. الري امبلانتيشن ميثود، طب احنا عايزين بنتارجت قدام ري امبلانت في البلفس عشان نزود السبونتينيوس بريجننسي ريتس، ولا ان ري امبلانت عشان بس نستفيد من الهرمونز بتاعت الاوفريز؟ يعني انت خدي شفتي وصلنا لغايه احنا هتستفيد من الهرمونز، مش شرط اللي هي تحمل، بس هيبقى في اوفريان تيشو فانكشننج بيطلع هرمونز، او الالترناتيف اللي احنا ندي هرمونال ريبليسمنت ثيرابي بايو ايدنتيكال، والبايو ايدنتيكال ده زي الاوفري كان بيطلعه قبل التريتمنتس ده ثرو اوت هير لايف. الكوست دي بتبقى ديفرنت ما بين كل حاله هتس انديفيدواليزد. يعني احنا هنعمل لده هنعمل الاوبشن الاولاني ولا الثاني ولا الثالث، تمام؟ بس يعني اتس فيزبل. هو طبعا احنا عشان نقلل الليت احنا ما بنعملش اي في اف سايكل كامله، احنا بنعمل اوفيوليشن اندكشن، ودي الكوست بتاعتها بتبقى الحقن اللي هي بتاخدها مع التريتمنتس، الادويه اللي بتاخدها عشان تستيموليت الاوفيوليشن، تمام؟ فالسايكل دي يعني طبعا مع غلاء الاسعار دلوقتي، بس هي تكلفه الادويه يا دكتور، هي تكلفه الادويه يا دكتوره، وبس بنعمل تكلفه الكرايو بريزرفيشن ايا كان بقى. لكن الاي في اف سايكل بقى اللي احنا بتتعمل بعد ما نعوز اللي هي تحمل، دي اللي ممكن بتاد كوست على العيان، دي بتاد كوست على العيان. شكرا.
انا كان ليا سؤال لدكتور عمرو.
نعم.
بس شكرا دكتور عمرو على المحاضره. انا بس كان لينا سؤال. احنا بنحول العيانين في بهية عندنا، العيانين اليونج بيشنت اللي هم تحت ال40 اللي هي نون ليبارا او عندها طفل واحد، بنحولهم قبل ما نبدا العلاج بنحول على الفيرتيليتي يونت، يا عين شمس يا القصر العين. او انا سؤالي لحضرتك، انا حولت العيانه قبل ما تبدا الكيموثيرابي وتاخد راندوم بروتوكول مع لتريزون. حضرتك كدكتور نسا يعني انا عملت اوفا بريزرفيشن، بعت العيانه تعمل الراندوم بروتوكول مع لتريزول، وجيت حضرتك تجمع اوفا لقيتها فيلد، وحضرتك عارف ان انا محتاجه ابدا نيو ادجفنت كيمو از ايرلي از بوسيبل. بتديها كام ترايل او بتديها كام فرصه عشان نعملها اوفا بريزرفيشن؟ اي هاف وان كيس راحت رجعت لي بعد 4 شهور. جمعتي اوفا قد ايه؟ جمعت 1 اوفا. انذر كيس بيجي لنا برضو بنات نحولها ترجع تقول لي انا عملت 1 ترايل مفيش اوفا اتجمعت وانا قلقت وجيت ابدا الكيماوي. المفروض
هو في دبل استراتيجي ممكن ثرو اوت ذا سايكل، تمام. ممكن يتعمل دبل اندكشن، يعني في الفوليكولار فيز مره وفي اليوتيل فيز مره كونسيكوتيف، يعني مرتين ورا بعض. بس هي البروتوكول نفسه كل ما نزود الاندكشن ثيرابي كل ما يبقى في اوسايت ريتريفال اكتر، تمام. فاحنا بنبدا بالاندكشن بتاع الجونادوتروبينز، تمام. اي راندوم ستارت ده هو طبعا كل ما نبدا بدري، يعني هي حظ العيانه لو جت في الفوليكولار فيز ده بيبقى البيست، طب جت في الليت ليوتيال فيز ده بيبقى شويه تشالنجينج، تمام. بس ايا كان انت بتعملي سترونج اوفيوليشن اندكشن بالجونادوتروبينز، بعد كده بتيجي لما الاوسايتس توصل ل 13 مللي 14 مللي بتدخلي انتاجونست عشان برضه ما تعمليش ايه، تعملي داون ريجوليشن. هو الموضوع بيبقى محكوم شويه وانديفيدواليزد، ما بتبقاش كل عيانه شكل الثانيه. بس الاندكشن ثيرابي هو المهم اللي انت يعني يعني تو بي سكسيدد من اول مره واب تو 2 سايكلز. طيب هو الديوريشن قد ايه؟ المفروض المينيمال ديوريشن من الستارت اب هو تقريبا 10 12 يوم، المفروض يبقى عندنا اوسايت. ممكن الموضوع ده يزيد شويه لو احنا عملنا دبل بروتوكول او دبل استراتيجيز ورا بعض، سكسيسيف استراتيجيز. الحاجه الثانيه اللي انت بناخد بعد الاوفيليشن ريتريفال ده تقريبا 5 ل 7 ايام كمان قبل الكيموثيرابي اندكشن، عشان اللي تزود داون ريجوليشن بتاع الاستروجين قبل ما نبدا، والجي ان ار اتش اجونست. يعني احنا ما بنديش الجي ان ار اتش اجونست ونبدا تاني يوم كيموثيرابي، لازم نديله فرصه عشان يشتغل، فبياخد له بتاع 5 ايام كمان. سن العانه بيفرق طبعا. تحت 35 يا دكتوره، تحت ال 35 سنه انا بص يا دكتوره، تحت 35 سنه انت لو مش عايزه تعملي لها عندها الماركرز بتاعتها كويسه، الاي ام اتش بتاعها 3 اتس اوبتيمم، او من 1 ل 3 يعني الانترا فوليكولار كاونت كويس، ماشي. انت لو مش عايزه تبداي الكيمو على طول، تمام. يعني في السن الصغير بعد التريتمنت النابرو تكنولوجي كان ليد الايه وتدي سكسس ريت اب تو 80% 80% سكسس ريتس، تمام. حتى لو احنا ما عملناش بريزرفيشن اوبشن قبل، لكن كل ما تعلي فوق ال 35 كل ما السكسس ريتس بتقل. فبتيجي ل 40 اذا كان العيانه ما بتبقاش اساسا في كانسر وبتدخل في لونج بروتوكول شهرين وما بتطلعش حاجه، وهي ما عندهاش اي حاجه ولا مستعجله. يعني هو الموضوع ده كونتروفيرس، بس كل ما العيانه سنها يبقى اقل كل ما السكسس ريتس بتبقى اعلى. شكرا جزيلا.
Thank you, Dr. Amr Abu Yazid. You raised many important points about this important topic. Thank you very much. Now I have the pleasure to introduce Dr. Raghda Yahya, lecturer of clinical oncology at Fayoum University. The talk is pregnancy in breast cancer survivors. The floor is yours.
Good afternoon, everyone. I'm Raghda Yahya, lecturer of medical oncology in Fayoum University and associate consultant in Baheya Foundation. I would like to thank you all for the kind invite, and I would like to thank Professor Dr. Amani Hilal. My topic will be complementary to both talks of Dr. Amr and Dr. Amira Dia. It's about what are the odds of pregnancy in a breast cancer survivor. Here is my agenda. To be talking about malignancies encountered in the reproductive age, we have various malignancies, including breast, ovarian, lymphomas, leukemias, pediatric solid tumors, testicular cancers, brain tumors, peanut bone tumors, and breast cancer in the reproductive age being the most frequently diagnosed malignancy and the leading cause of cancer deaths in women worldwide. And it's a commonest invasive malignancy that affect women in the reproductive age, and 30% of these patients are premenopausal, with 10% aging 35 to 45 years old. Hormone receptor positive being the most common type of all cases. The possibility of getting pregnant after breast cancer, it's a key question for all of us as oncologists, and we are facing, as I said all of or most of the cases are being hormone receptor positives, what are the odds of getting pregnancy, and is pregnancy will worsen the breast cancer condition and make it recur due to the condition of the hormonal status of the patient? It's a key question for all of us and also for the patient. And the historical context, for many years we were cautious about this, particularly for patients with hormone receptor positive, as we said. And we have here modern research and recent studies and clinical trials that notably طبعا the positive trial, I will talking about it later, that provide strong evidence about pregnancy in breast cancer survivors. As modalities of breast cancer management, including surgery, chemo, radio, endocrine, and targeted treatment and immunotherapy, and this multimodality treatment is being current standard for the care and lead to infertility due to various causes, including the disruption of the hypothalamic pituitary gonadal axis and the immunological and cytotoxic injury of the germinal epithelium within the testis, and the anorexia cachexia syndrome and psychological issues, including the anxiety and depression. With chemotherapy, as Dr. Amira said, I will not go in details, but the degree of ovarian damage dependent on the age, on the dose used, and the baseline ovarian reserve when we start the treatment, as most of the chemotherapy goes apoptosis of the growing follicles and activation of the resting follicles that enter into a subsequent apoptosis, leading to burnout and fibrosis and of the stromal blood vessels. The clinical manifestation can vary between amenorrhea to premature menopause and varying degree of infertility. This incidence of temporary definitive chemotherapy induced amenorrhea ranges from 22 to 61% in women under 40, going up to 61 to 97% in those who are above 40, indicating that age plays a key role in this. As we can see, with the arrow going from the least toxic to the most toxic to the ovaries, we can see the alkylating agent and precisely the cyclophosphamide as being one of the most chemotherapeutic agents used in the treatment with the most toxicity on the ovaries. As we can see also, it varies according to the level of the primordial follicle and ovarian reserve that goes down with age, and with the introduction of chemotherapy, we have a rapid decline in this ovarian reserve, increasing more and more above the age of 40. As we said, alkylating agent, the highest toxicity, going to platinum compound has the medium risk of amenorrhea, and the anthracycline and fertility have the medium to low toxicity. The fertility considerations of us is the age and of the patient and the presence of partner or not, the general health of this patient and the available time I have before treatment of cancer, and the option of surveillance or the use of less gonadotoxic chemotherapy as case by case. And what is important is, especially in the early case, is the incorporation of the oncotype DX to allow to stratify patient need to chemotherapy as case by case, so we can skip chemotherapy in those who will be in an early stage and will not need the benefit of adding chemo or the toxicity of adding it. The timing of the treatment, starting to the breast cancer, the chemotherapy delay for 1 month. Do I have this time to make a stimulation or oocyte retrieval? And what we call it the HER2 adjuvant therapy, which I can use it prior to the use or in adjunct to use of chemotherapy with the GnRH analogs, and all of the patients should be offered fertility counseling. Here, the ESMO guidelines, it tells us that any newly diagnosed breast cancer in a premenopausal female or the female in the reproductive age, she should be counseled for fertility and should be asked if she desires to preserve fertility or not. In case she does not desire to preserve fertility, I should offer her desire to preserve ovarian function or not. In case she does not want to preserve the ovarian function, I will offer no treatment. In case she desires to preserve the ovarian function, I shall go with the GnRH during the chemotherapy. And in case she desires to preserve the fertility, I should look it as a case by case. If I do have time to start, or I don't have, as the patient is advanced. What are the time? I do have more than 2 weeks or less than 2 weeks. If I do have more than 2 weeks, I can go to ovarian stimulation with oocyte embryo retrieval according to the case. And if I do not have this much time, I can go to ovarian cryopreservation. Both of them I can go plus or minus GnRH analogs to as an adjunct treatment to this. I will not go further details of embryo cryopreservation, but it's we call it ovarian hyperstimulation and embryo banking, which is one of the successful forms of fertility preservation. The limitation for us, and it was concerning to us, it's the high estradiol level, and we can call it the estradiol or estrogen surge. And this was a query question for us if it will have an effect on recurrence or increasing increased the toxicity or increased the progression of the breast cancer situation. But the use of AI and especially letrozole have now some of balancing effect, and we have data that it's safe for now. And also the limitation was the delay of the cancer treatment. The oocyte cryopreservation recommended for the patients facing infertility due to chemotherapy or other gonadotoxic therapies, and when the woman is unmarried or does not have a partner for right now, by slow freezing and rapid freezing. And GnRH agonist and antagonist, and the mechanism of their action can be an agonist. They cause pituitary desensitization that ensures within a 1 week or two to reduce the number of the primordial follicles destroyed by these toxic agents, and can reduce the blood flow going to the ovary and reduce the delivery of chemotherapeutic toxins. What about the antagonist? The antagonist can cause rapid inhibition of gonadotropin and sex hormones, sex steroid secretion, leading to immediate downregulation. What is the ASCO guidelines in this oncofertility? To preserve the full range of options to all of the patients and discuss as early as possible, and all the patients who have interest in fertility preservation, they should go to oncofertility specialist, and no one could be denied so long as she is in the reproductive age, and the concerns should be discussed in details with her oncologist and oncofertility specialist. What is the waiting period to start a pregnancy? As was a common recommendation, it was to wait at least 2 years for all of your early stage breast cancer cases, as the risk of recurrence and the risk of returning of the cancer will be in the first couple of years following that treatment. But we can say it's not more like this. It's waiting depending on what you are using in the treatment. In case of the chemotherapy, what should you to wait after chemotherapy? The waiting is for at least 6 to 12 months after completing chemotherapy before you attempt to pregnancy. And the reasoning in that was this waiting period allows you time for the eggs potentially damaged by your treatment to leave the body naturally, and also ensures that chemotherapeutic drugs have cleared out of your system. What about the endocrine therapy? As endocrine therapy is very, very important because most of our women presenting with breast cancer, they have hormone receptor positive status, and the typical treatment length will be very long, from 5 to 10 years in certain situations. So the patient can be discussed the stopping of hormonal treatment, and we will see in the positive trial. What is this positive trial? This trial, it was asking the question about when can we stop, or is it safe we can stop the hormonal treatment at a certain point and allow patients with early breast cancer to have a trial and to attempt a pregnancy. Actually, many young patients and survivors desire this to keep the pregnancy or the fertility, and there has been concerns about pregnancy that might increase the risk of early stage breast cancer. And prior studies studies looking back to the strategies and database, and breast cancer after breast cancer, it does not worsen the disease outcomes regardless of the hormonal receptor status. In this trial, it was an international prospective single-arm trial that was addressed this question carefully. They enrolled about 500 patients in different centers, and those patients, they share that they were early breast, and they finished about from 18 to 30 months of adjuvant endocrine treatment. So we can all median of 2 years of endocrine therapy, and they allow them for a timing of 3 months to wash out the hormonal treatment, and then after the 3 months to start to have 2 years to allow conception, delivery, plus or minus breastfeeding according to the case, and then after she finishes the 2 years to go for back to her hormonal treatment, either 5 or 10 years according to the case. Those population actually, they are about, as I said, 516 patients. The median age was 37 years. Most of them were non-leprous, and 94% were at early stage 1 and 2, and 62% received previous chemo. And median time from the breast cancer diagnosis to be enrolled was 29 months, and the median follow-up was 41 months. As it was a single arm, we needed to address the breast cancer free interval and the disease relapse free interval in comparison. So they studied it in relation to the results of the retrospective results of the SOFT and TEXT trial. They found out that the breast cancer free interval, as we see, and the distant relapse free survival in both groups were more or less similar. The cumulative incidence at 48 months, that 8% had cancer recurrence or deaths in 9 deaths before resuming the endocrinal treatment, 76% resumed the endocrine treatment, and 15% were not yet resuming it. About 74% of the women who had at least one pregnancy, and the 70% was in the first 2 years, with a total of 507 pregnancies. 317 had at least one live birth, 64% of all women, and 86% of those who became pregnant. 19% had at least one miscarriage, and 3% had at least one abortion, and 8% of the offspring were low birth weight, and 2% have birth defects, and we can see these incidents are quite low. So the initial results, it's temporary interruption of endocrine therapy to attempt a pregnancy among young breast cancer survivors is safe in short-term follow-up, and most women, 74%, had at least one pregnancy. As we said, 70% was in 2 years, and birth defects were very low, and apparently it's not associated, or it's not due to disease treatment outcome, and the long-term follow-up to monitor endocrinal treatment and disease outcome is needed, and this data stresses the need to incorporate patient-centered reproductive health care for the young woman with breast cancer. What about the waiting period based on the treatment type? Again, we have the targeted treatment if patient is having trastuzumab. The general waiting period is at least 7 months after the last dose of Herceptin. And the reason for that was that there is a risk to the fetus with having Herceptin while you try to get pregnant, because it leads to low level of amniotic fluid and underdeveloped lung, and subsequently affecting the fetal health. Also, the long half-life of Herceptin, and Herceptin has a half-life of 28 days, and this can vary according to the dosage, and the drug generally takes about 5 and half-lives to be cleared from the body, so meaning that the Herceptin can persist in the circulation up to 27 weeks over 6 months. So a period of 7 months on the guideline accounts for individual, to be sure that you are safe after stopping Herceptin. مش عارفه انا بشيلها. ايوه تشيل. What about the immunotherapy? Does it carry any risk on fertility? As immunotherapy can cause thyroiditis, adrenalitis, hypophysitis, all of which may affect fertilization through impaired hypothalamic pituitary ovarian axis, and appropriate hormone replacement would be necessary to maintain fertility in these cases. So individualized planning is always the key. You should consult your doctor about timing of your pregnancy, and consult your oncologist and oncofertility specialist, and consider the cancer stage, the cancer type, the dose of the treatment given, if you have localized disease or advanced disease, early or advanced, if I may say, and factor in the treatment type also, do I have chemotherapy, hormonal therapy? All of them will affect the timing I can start to get pregnant. As pregnancy outcome and risk, there is no increased recurrence risk in many cases, and no negative impact on survival. On the contrary, there are some studies that showed that on the long term, getting pregnant is somehow protective against breast cancer. And disruption, as we said, to back to the results of positive trial, we can disrupt the hormonal therapy after about 2 years to try to make the patient get pregnant. Also, the concerns of pregnancy in breast cancer survival. As for the mother, we may say that she will have any concerns about what are my complications of getting pregnant. Do will have a preterm delivery, having a baby with low birth weight, undergoing cesarean sections. Also, the hormone therapy and the pregnancy, the hormone therapy will increase the risk of my pregnancy or not, and the risk of recurrence, and how should I wait to start? All of these have been addressed properly in the positive trial. And for the baby, we can see from even the results of the positive trial that there is no increased risk of birth defects, as babies born to these women are not at increased risk of genetic defects or long-term health problems compared to those born to women without a history of breast cancer. But the potential for other issues like to have a low birth weight, a small size, or preterm birth, that's all. So, as a summary, pregnancy is possible. Most young women who have had breast cancer, they can become pregnant after treatment, and the pregnancy is safe for both the mother and the child. And new evidence from the positive trial demonstrate that interruption of endocrine therapy for pregnancy is safe. Careful planning is quite needed, and treatment can impact fertility, so planning is essential from the start. And multidisciplinary care and cooperation between the oncologist and the fertility specialist is greatly important from the start, or before starting the planned treatment for the patient. Thank you so much.
Thank you. Thanks. Thank you so much. Thank you so much. Thanks, Professor Dr. Raghda, for your elegant presentation. Our next speaker will be Professor Dr. Iman Sobhi. The presentation will be about lessons learned from positive trial regarding the predictive value of fertility. Good afternoon, إن شاء الله يا رب.
Good afternoon إن شاء الله يا رب، مش هطول عليكم. المحاضرة إن شاء الله صغيرة، والحمد لله يعني في كذا حاجة فيها خلصت في المحاضرات اللي قبل كده، فهنعدي عليها بسرعة. المحاضرة عن ال lesson learned from the positive trial regarding the predictive value of fertility in young female. Breast cancer in young females طبعا under 40 is the most common. Breast cancer is the most common in young female, والincidence unfortunately still rising. This is a unique challenge to us as regard the fertility planning to the patient. This is why the introduction of the positive trial was a landmark in this field, which is planning the interruption of hormonal treatment to get patient to get pregnant, then continue the hormonal treatment after. The design focus was on stopping single-arm international trial, with the primary goal was determining if the interruption of the hormonal treatment will get a negative feedback to the patient or not. الترايل design of the trial on a 3 panels. أول حاجة فيها كان wash out period after the end of the hormonal for 3 months stopping of hormonal treatment before allowing the patient to start the fertility planning. Total interruption window was up to 2 years. The assisted reproductive technology was advised to the patient if she had 12 months after the interruption of treatment without natural conception. A safety outcome, the first goal of the treatment is it's safe to stop hormonal treatment for a period of time to allow the patient to get pregnant. It's actually a risk of breast cancer recurrence or breast cancer event in general was only 44 patients against the safety threshold 46 patients, which was set from the soft and text trials in the same age group. The incidence was only 8.9% versus 9.2% in the control cohort group. Achieving the pregnancy outcome goal بقى, if it's safe for the mother or the fetus. The positive trials have a high success rate
Total cohort in the study was 497 patients. The pregnancy success rate was almost 74% of patients who achieved to have at least one live birth. A reduced risk observational hazardous ratio was only 0.53%, suggesting a negative association with pregnancy. Highlighted طبعا in the younger patient were more decreased risk in getting pregnant. Under 35, the percentage of success rate was almost 85%, decreased to almost 52% only in patients older than 40. The pregnancy outcome, fortunately, alhamdulillah, can mostly a live birth, full-term baby, which was the same rate as the normal person with the same age, which gave us a hint that pregnancy in a breast cancer patient doesn't carry an extra risk to the mother or to the fetus. الكونسيرن الثاني اللي كان عندهم في البوزيتيف ترايل do the patient will continue the hormonal treatment after delivery or not. Actually, surprisingly, the number of patients resuming the hormonal treatment was almost 73%, with only and the other part, which was not starting hormonal treatment, 79% of them was actually still after the 2 years still trying to be conceived, which gave them a hint that the patient enrolled in the study was restricted to continue their prolonged hormonal treatment after delivery. The fertility predictor in the trial, the most common fertility predictor in patients in the trial was the age, which was related to almost all the hormonal profiles of the patients. The anti-Mullerian hormone was the marker which was tested with the most common marker tested in the study, which is the most accurate non-invasive marker of ovarian reserve. The law, it was designed to test it in the 6 and 12 months from the start of the study. Low ovarian reserve was observed in 47% of patients, which is anti-Mullerian hormone lower than 0.5 nanogram per milliliter. But fortunately, almost 65% of patients with low ovarian reserve at the 12 months achieved to get pregnant after the 12 months, which indicates that the anti-Mullerian hormone is a predictor, but low anti-Mullerian hormone, it's not a complete contraindication of getting pregnancy. The most common predictor of low ovarian reserve was the age and the prior chemotherapy. And actually, in the positive trial, they didn't restrict it on which type of chemotherapy was given to the patient. They highlighted all the patients who received chemotherapy without telling us which type of chemotherapy they received. And this is one of the criticisms of this study. And the type of the endocrine treatment, whether it's tamoxifen, aromatase inhibitor, gonadotropin-releasing hormone, it doesn't make any difference in the low ovarian reserve for these patients. تاني حاجة they assess the premature ovarian insufficiency, which was tested as oligomenorrhea and the elevated FSH level more than 500 international unit per liter. It only was tested if the patient passed the 12 months without getting pregnant. So the result was low as expected to other studies. It was only 10% of patients of the 142 patients who didn't got pregnant after the 12 months. They only 15 patients, all of them received the previous chemotherapy, and all of them have the low anti-Mullerian hormone level. Two main causes of premature ovarian failure with the age related, with women under 35 was only 2.5%, and women 40 or older 15%. The treatment, the combination of ovarian function suppression and aromatase inhibitor was a higher incidence of premature ovarian failure combination of ovarian function suppression and aromatase inhibitor was coincidence with a higher level of premature ovarian failure, 15% versus 10% only in selective estrogen receptor modulator. Third thing was evaluating the ovulatory function and oligomenorrhea. It's tested the luteal phase, the level of the progesterone level at 6 months, which was more than 3 nanogram per milliliter. The menstrual irregularity was observed in almost 31% of patients before month 12, and at 6 months, 16% of the patients who didn't experience pregnancy, 60% was ovulatory. This was an indicator that the ovulatory function and progesterone levels not affected by spontaneous pregnancy. Thyroid function and prolactin level also tested in this study, and they giving a negative impact on pregnancy. Patient tested high level of menstrual resumption post-treatment, almost 94% after 1 year, and this is mostly related that most of the patient, a big number of patients didn't receive chemotherapy. The resumption after 6 months was related to chemotherapy, and patients receiving chemotherapy and gonadotropin-releasing hormone, 58% resumed period. Only 81% didn't of chemotherapy alone without gonadotropin-releasing hormone. Assisted reproductive technology also was available in this study if the patient didn't, as the patient failed to conceive spontaneously after 1 year. طبعا with the cryopreservation, with the 36% of patients had cryopreservation, in vitro fertilization 16%, frozen embryo 14%. طبعا زي ما دكتور عمرو قال ان هي الموست سكسسفول ريت كانت مع الامبريو ترانسفير سكسس. دي برضه الحاجات الدكتور عمرو قالها. في حاجه انترستنج قوي في الاستادي، حبيت بس اقولها حاجه بره الفيرتلايزيشن، ان they allow the patient to get the experience of breastfeeding their child. يعني دي حاجه كانت يعني اللي انا عارفاه طول عمري ان ممكن breastfeeding شويه قالت contra indicated مع البريجننت مع الفيميل بيشنت، بالذات انها هرمونال بوزيتيف. فهم هنا they let the patient if she desired to breastfeed her child to get a breastfeeding for 4 months post delivery. The number of 317 patients, there's successful pregnant, 62% experienced breastfeeding with negative feedback on the recurrence. Summarization: breast cancer is safe. Breast cancer interruption of hormonal treatment to get pregnant is safe. إن شاء الله يعني، بس it's still needing a prolonged follow-up. The predictor of pregnancy success, the most important predictor is age. Age less than 35 carrying a high rate of success in pregnancy rate. The hormone markers, the anti-Mullerian hormone, the FSH and E2 level are also a predictor of breast cancer if she can fertility preservation or not. بس شكرا.
Thank you, Dr. Iman, for your elegant presentation. And lastly, any question for Dr. Iman? Thank you, Dr. Iman. Lastly, after these elegant presentations, we will introduce lastly presentation will be presented by Dr. Marat Meher.
Good afternoon. Good afternoon. My name is Mirat Meher. I'm a medical oncology specialist at Baheya and assistant lecturer of medical oncology at NCI. It's a great honor to participate in such a fruitful event. Thanks to Dr. Amani and thanks to our chairpersons and the audience. My case presentation today is about a very interesting subject. It's called pregnancy-associated breast cancer, which is defined as breast cancer diagnosed during pregnancy or within 1 year of delivery, affecting 1 in 3,000 pregnancies and accounting for nearly 7% of all breast cancers diagnosed per year. The incidence is actually increasing due to increase of breast cancer in young women and delayed childbearing. Our case is about female patient, 31 years old, performance status 1, positive family history. She complained of right breast lump of 2 months duration and nipple discharge. She is pregnant in the first trimester, 10th week. It's her first baby, so it's a precious baby. The expected date of delivery in April 2025, week 37. So which modalities do we use for diagnosis? Delay in diagnosis is well documented because breast density and nodularity increase with pregnancy, complicating the interpretation of clinical examination and breast imaging. The best modality for diagnosis will be the breast ultrasound, used to assess the extent of the disease and also to guide biopsy. It's preferable for core needle biopsy for immunohistochemistry and hormonal receptors assessment and HER2 analysis. Mammography with shielding can be done safely and accuracy is reported to be more than 80%. Actually, breast MRI without contrast is not effective in distinguishing hypervascularization related to malignancy from pregnancy-related changes. Also, breast MRI with gadolinium is contraindicated as it passes the fetal circulation, causing rheumatologic or inflammatory conditions. This is an image for 2 different patients, mammography showing asymmetry with architectural distortion and ultrasound showing hypoechoic irregular mass with speculated margins and posterior shadowing. As for the staging, it should be guided by the clinical stage, clinically node negative T1, T2, chest x-ray with abdominal sheathing and laboratory tests will be appropriate. For node positive or T3, T4 disease, we can add ultrasound of the liver and MRI without contrast, MRI spine without contrast. So it's all about the fetal radiation doses. We should decrease the fetal radiation doses. MRI, X-ray and mammography can be safely done, but usually not avoided. Bone scans, PET CTs are usually avoided. So what our patient did, bilateral breast or ultrasound showing right breast heterogeneous parenchyma with scattered micro and macro calcifications by RATS4. True cut biopsy, invasive lobular carcinoma, ER positive in 90% of the cells, PR 80% positive, and HER2 negative. BRCA test was positive, pathogenic variant detected in BRCA2 gene. Unfortunately, breast cancer during pregnancy is often axillary lymph node positive and large primary tumor size. Also, usually it's poorly differentiated, 70 to 100% infiltrating ductal carcinoma, mostly hormonal receptor negative and 30% HER2 positive. So what do you think the best option for management? Should the patient go for upfront surgery followed by adjuvant therapy? Should she receive neoadjuvant chemotherapy or neoadjuvant endocrine? We'll see. Important notes about the management, it should be done by MDT, collaboration between oncologists, surgeons, radiotherapists, obstetricians, pediatricians, and psychologists. Also, genetic testing is very important as these are young women. And treatments are scheduled around the gestational age to minimize risk to the fetus and the mother. So the patient underwent upfront surgery, right breast nipple sparing mastectomy with axillary lymph nodes sampling, showing invasive lobular carcinoma grade 2, pathological T2 and 1, lymph node 1 positive over 3, lymphobascular invasion is detected. It was done in the 12th week because fetal ultrasound after surgery showing a mean gestational age 13 weeks and 6 days. So about the relation of pregnancy-associated breast cancer with anesthesia, there are 3 types: local for minor procedures by lidocaine, regional by various nerve blocks, including thoracic, paravertebral, subpectoral, serratus anterior, and epidural block, and general anesthesia. Most anesthetic agents are safe, except nitrous oxide is better avoided, especially in the first trimester. Furthermore, it's very important for intraoperative fetal heart rate monitoring. Prevention of hypotension and hypoxia is essential. Cardiotocography is useful as analgesia altered the identification of mild early contractions. And in addition, heparin prophylaxis as there is pregnancy associated hypercoagulability. This is a preoperative assessment of the pregnant patients. We should know if the patient received neoadjuvant chemotherapy or not for the sake of myelosuppression, thrombocytopenia. It can cause intraoperative bleeding, leukopenia. It can cause postoperative infection. So we can postpone surgery for 4 to 6 weeks. And we should also notice the signs of anxiety or depression for patient counseling and the risk of venous thromboembolism. About our disease and surgery. Surgery is safe in any trimester, especially the second trimester is being optimal. Mastectomy is preferred and axillary nodal dissection. Breast conserving surgery is not discouraged, especially if adjuvant chemotherapy is needed, and we can delay radiotherapy until after delivery. Sentinel lymph node biopsy is not discouraged also, but blue dye is contraindicated, so technetium sulfur colloid can be safely used. Our patient received 5 cycles ACE and then stopped chemotherapy 6 weeks before delivery, delivered in April, and continued then adjuvant Taxol weekly after delivery, then hormonal treatment, AI Zoladex, and radiotherapy. So what about the systemic treatment? The risk of teratogenicity in the first trimester is highest, considering 17%. This comes down to less than 2% in the second and third trimesters. Our greatest experience is with anthracyclines and alkylating agents. Data from Andy Anderson study, it included 57 patients, and all 57 patients had live births, no fetal deaths. And all neonates were completely normal and healthy. There's 1 child with Down syndrome and 2 children with congenital anomalies, including clubfoot and congenital ureteral reflux. So it's safe to use FAC during the second and third trimester. As for taxanes, very important in breast cancer. Also, the transplacental transfer of paclitaxel was found to be less than 5%. Zagori et al. Included 50 patients from 16 studies in a systematic review evaluating role of taxanes during pregnancy. In 76.7% of cases, healthy, completely neonates were born. So the NCCN panel recommends weekly Taxol after the first trimester, of course. Another agent, of course, methotrexate is contraindicated due to third space effects and teratogenicity. Hormone therapy should be avoided until after delivery. The use of tamoxifen can cause teratogenicity and spontaneous abortion. Other agents as PARP inhibitors, immunotherapy, CDK4/6, and antibody drug conjugates are contraindicated during pregnancy. Anti-HER2 treatment, trastuzumab, is also contraindicated. The HER2 receptors are present in fetal renal epithelium and can cause decrease in fetal urine output and amniotic fluid volume, oligo and hydramnios, increasing the fetal limb malformations and pulmonary hypoplasia. Other anti-HER2 drugs like pertuzumab, TDM1, trastuzumab deruxtecan, and neratinib all are contraindicated. As for the supportive medications, antiemetics, analgesics are safe. Corticosteroids, dexamethasone should be avoided because of the risk of fetal growth restriction and neurocognitive defects. Other steroids as prednisolone, methylprednisolone, hydrocortisone could be preferred. Low molecular weight heparin is the preferred anticoagulant. GCSF and erythropoietin are safe. And it should done, breastfeeding counseling should be done even with supportive care medications. Regarding radiotherapy, the standard of care is to avoid radiotherapy during pregnancy. It should be delayed until after delivery. There are radiobiological models just to estimate the dose tolerable for the fetus in the first trimester, which is 0.02 gray. And the second trimester, 0.2, and the third trimester 0.5. This is just for academic use. It's not used. So to sum up, in the first trimester, weeks 1 to 12, surgery probably safe after 9 weeks, with, of course, cardiac motion monitoring. Chemotherapy, radiation, anti-HER2, and endocrine are contraindicated. In the second trimester, safe surgical window from 12 to 24 weeks. Anthracyclines and taxanes can be used. Serial fetal ultrasounds for growth. Radiation, anti-HER2, and endocrine are contraindicated. The third trimester surgery is safe with intraoperative fetal monitoring and neonatal resuscitation. Radiation, anti-HER2, and endocrine therapy are contraindicated. Important notes, we should withhold myelosuppressive therapies within 3 weeks of delivery and avoid iatrogenic prematurity in the absence of clear maternal benefit, and delivery should be done by obstetric indications. Pediatric team also should be available. Another case scenario, female patient, 35 years old, performance status 1. She's pregnant in the third trimester, 7th month, and it's also precious baby after 6 trials of IVF. Breast ultrasound show left breast lower inner quadrant distortion and pathological left axillary lymph nodes. True cut biopsy, it's mixed invasive duct and lobular. ER 3/8, PR 5/8. HER2 here is amplified. Pelvic abdominal ultrasound done showed multiple liver metastases. So the patient is pregnant, third trimester, metastatic, HER2 positive. What do you think we shall do? Shall we convert liver mets by CT or PET-CT? Shall we give anti-HER2? Of course, as we said before, no. So the patient started AC 2 cycles and then stopped before delivery. She delivered in May, and then a triphasic CT done showed hepatomegaly with bilobar hepatic focal lesion, as showed in the image. Then she started docetaxel, Herceptin, Perjeta, received 4 cycles. CT show regressive disease, so she continues. She received 2 more cycles. Thank you.
Thank you, Dr. Meret, for your nice presentations. 2 cases in exact time. Thank you.
Do we have any questions from the floor? Actually, your cases, Doctor, were very interesting, especially the first one. Do we have any comments? Dr. Amr, do you have any comment on the first case? Do you have any comment on the first case? No.
Dr. Meret, thank you very much for the first case. I would like to ask about small points. Yeah. For this patient, do you expect that if you have tested the HER2/neu and the hormonal receptors and Ki-67 before the decision for surgery, is that would change the line of management? تفضل.
الفيرست كيس كانت في الفيرست ترايمستر، فاحنا الكيموثيرابي والانتي هيرتو تريتمنت better avoided في الفيرست ترايمستر. We should start from the second or third trimester. And patient clinically was T2 and 0, so the best option
was N0 or N1. I read it like
N1 pathologically, but
okay.
clinically it was N0.
Okay, I'm asking for that. Yani, if she is low risk patient, just for the, if I'm wrong or right, you can tell me. And I'm asking for that. You have to know the risk of the patient before you ask her to start treatment or to terminate the pregnancy or to wait till she deliver and start the treatment.
Yes, of course.
This is the point.
Yes,
Yeah.
yes.
Thank you very much.